Dobro veče. Evo nas na trećem simpozijumu današnjeg 7. kongresa interventnih kardiologa Istočne Srbije. Ja moram da se zahvalim mom kodirektoru ovoga kongresa, Vladi Mitovu. Mi smo otvorili marta meseca 2014. salu u Zaječaru i uspostavili jedan edukativni kongres koji je deo chapter našeg kongresa Udruženje kardiologa Srbije i to je jedan od naših interventnih kongresa. Evo napokon u pandemiji COVID-19 virusa mi smo se ovde okupili, biće oko 250 do 300 kardiologa, interventnih kardiologa, internista ovde na Staroj planini. Ovo je drugi po veličini rezort pored Kopaonika, ski centar u Srbiji. Evo kongresno jedno mesto. Naš miting današnji je krenuo u 14 časova, a treći miting je Update Current Cardiology, znači najnovije stvari u kardiologiji 2021. Ovde je s nama profesor Aleksandar Osijev iz Moskve, čovek koji u zadnjih 20 godina nas pomaže. Ja ga znam još dok je bio u Novosibirsku, bio sam tamo na kongresu, sada je u Moskvi, jedan od najboljih interventnih radiologa Rusije koji ima najveći fond urađenih intervencija, master of CTO kluba evropskog i jedan veliki naš prijatelj. Drugi je gost Natan Vong iz Irvajna, čovek koji je pomogao mnogo srpsku kardiologiju i Udruženje kardiologa Srbije i Udruženje Republike Srpske. On je naš idejni tvorac za naš 34. ogranak Američkog koledža kardiologa za Srbiju i Republiku Srpsku. Takođe ovde je profesor Slobodan Obradović, akademik Duško Vulić, ja mislim preko sajta će se obratiti, koji je bivši guverner 34. čeptera Američkog koledža kardiologa, takođe i Zoran Vujković, prodekan Medicinskog fakulteta u Banja Luci, jedan od velikih naših prijatelja. Evo imamo znači sve naše prijatelje velike koji žive na raznim stranama, nama bliskim i prijateljskim, i evo ja bi pozvao I invite my friend Professor Alexander Osiev from Moscow. His topic CTO, what is new? Šta je najnovije u CTO intervencijama? What is new in CTO interventions? Will be presented our friends Professor Osiev. Here you are, my friend.
My dear colleagues, dear friends, it's a great pleasure to make presentation here at a nice conference hall at ZASINK. Now I work at MedC Clinic. It's the biggest private net in Russia, and the topic of my lecture is CTO and what is new. And you know, our internists, our cardiologists believe in a legend that there is no need in CTO recanalization, and it's bad for health, our patient. And there is just a minute. The reason is there are microchannels and collaterals which can provide good antegrade or retrograde flow. It's enough to avoid ischemia, and it's enough to have good result of treatment, medical optimal therapy. So sometimes we can see huge injury and no reason to open artery because no tissue there and no need to recanalize this CTO. And but unfortunately, collaterals can provide only 40% of antegrade blood flow at rest, and only 10% during stress. And you know, a lot of studies and meta-analysis which show significant recognition of CTO resulted in overall improved left injection fraction and improved survival. And if we compare outcomes of successful and failed CTO, chronic CTO recanalization, of course, it's MACE and prognosis is better for patient with successful result. And just a minute. And you know, ischemia is an independent predictor of adverse events, and if we treat ischemia, we can improve situation with our patient. And I think it's first 5 years study which compare optimal medical therapy and the recanalization in case of chronic total occlusion. And you can see when you use drug-eluting stent, which associate with PCI, and in 5 years we can see reduced incidence of death and myocardial infarction. I think it was first study, and now it's I think it's most important trial. It's pivotal trial which compare recanalization of CTO and optimal medical therapy in 10 years, 10 years follow-up study. So here you can see its curve. It's cardiac death, Kaplan-Meier curves. It's 10 years result. You can see mortality, it's cardiac death in case of CTO recanalization and optimal medical therapy. I think we can say if you have CTO and we will have to perform recanalization of this lesion. So, you know, CTO recanalization learning stages. Of course, we have started with integrate approach, then integrate to learn our integrate re-entry, retrograde approach, and retrograde re-entry approach. And we have enough wires, and wires is a main our tool. It's a main device to perform recanalization, and we have to choose, and we have to know all wires in order to use it, in order to perform recanalization of CTO. Of course, there are a lot of pitfalls, a lot of tips and tricks how to make shape, how to shape tip, and to perform, to find some channels and perform recanalization successfully. So most important, it's my choice. Most important contemporary tools now, I think it's Stingray to perform integrate re-entry technique, and some new wires. It's like Solar 03 wires, Gaia Next, and Sintai and Judah wire. So it's its study compare subintimal or versus interplaque recanalization coronary artery, and now we can say it doesn't matter if we assess OCT in 1 year. It's a similar result, and it doesn't matter. And recanalization of CTO, it's good for men and women. It's a good technique for women and men too. As far as cassette aortic valve replacement for patients with CTO, of course, we have to treat more often cardiogenic shock and some complication and acute myocardial infarction for patients with CTO and TAVI procedure, but it's a similar mortality. So, I draw your attention about few novel techniques, and if you know this technique, and you know Emmanuel Brilakis, and sometimes we have hematoma, and if we can use microcatheter and use syringe and negative suction in order to treat hematoma, and then perform to find to puncture to true lumen. So it's for its example, and one more technique. It's Antonio Colombo team technique, and sometimes we can't find true lumen, and we can inflate balloon like it in order to have some communication from false to true lumen. It is work indeed. I try to do it. It's good technique and some and example. And example, and I was here, and we can find true lumen, and it's interesting methods of recanalization. Sometimes in failed case, we can perform plaque modification strategy and use drug-eluting balloons in false lumen, and in months or 2 months or 3 months, we can find we can perform recanalization easier. It's 3 case. How does it work? The doctors inflate drug-eluting balloon in false lumen, and then perform recanalization antegrade in 1 month. It's a good, intelligent decision, and I never use it, but I'm going to try. Some report about robotic assistant chronic total occlusion. So we can perform some step by robotic, but unfortunately we can't perform all procedure with robotic assistant device. But we have to try do it in order to decrease some procedure time and X-ray for doctors. So and now we know CTO algorithms. It's modified hybrid Euro-CTO algorithm, Asia Pacific and North American algorithm. All algorithms similar, and for example, this it's North American and Euro-CTO, and Japanese algorithm And of course, we have to use dual injection, and then also it's good support for our daily practice. And I can conclude now. So we have new data about result of CTO if compared with optimal medical therapy. And we have new devices, and we have good algorithm. And now we would be nice to have new CTO guidelines in order to move this thing more and more. Thank you for your attention and your support. Thank you very much. Thank you.
Thank you, my friend. Thank you, Professor Osiev. Do you have any questions from the audience? I would like to ask one question, Professor Osiev. What do you think about idea study, especially intervention cardiologist according optimal medical therapy? What do you think from point of the especially CTO master as you? Okay.
I think it's not enough 1, 2, 3, 5 years to assess result optimal medical therapy if compared with recanalization. But if we investigate more years or to 10 years, of course, atherosclerosis is a aggressive and mortality, of course, more in optimal medical therapy group. And now you can see I show trials. Optimal medical therapy it's not good option for our patient with CTO and ischemia. If it's ischemia, one way, the CTO recanalization.
Thank you very much for your very great presentation. I now invited Professor Nathan Wong from Ireland, our very good friend from us, who has supported us very much in the last 10 years. Especially, he supported our 34th chapter, American College of Cardiology, Serbian Society, and Society Republika Srpska. His topic, should we have a lower LDL C target for prevention atherosclerosis? Here you are, Nathan.
Does a slide show up there? Oh, okay. Oh, okay. Okay, Dobar večer, and I want to really express my thanks to Professor Mitov here, and for organizing such an interesting and fantastic conference, and for inviting me to participate. Also, Professor Nedeljkovic, who I've known for many years, and you've been a great host to me. I think this is my 5th visit to Serbia, and I've enjoyed visiting also Zlatibor and Belgrade, and also thank you, Dr. Milan here, for all your help with my visit today. Really appreciate it. So after that fantastic lecture from Professor Osiev on CTO, a very important technique, we're going to switch to prevention. So I hope you can make that switch to talking about prevention, which is my specialty. We're going to talk about the evidence for lower LDL cholesterol goals. Okay, so I'll take my mask off. It's easier to talk. And let's see if we can advance. How do we advance here? I think. Okay, these are my disclosures. So we're all familiar that in certain hunter-gatherer populations, cholesterol levels are very, very low, like 100 to 150. And so clearly we know that low cholesterol levels are viable. Human neonates have cholesterol, LDL cholesterol levels in the 30 to 75 range. We also know in hunter-gatherer populations that levels that atherosclerosis is rare. In this Tasmania Aboriginal tribe, which is in South America, some of my colleagues looked at coronary calcium levels and found coronary calcium to be essentially absent as compared to white men, where it dramatically increases with age, as we know. So next, we have seen an evolution of guidelines. I first started working as a prevention cardiovascular epidemiologist in 1988, when our LDL targets for high-risk people were below 130 milligram per deciliter. And then you can see it's decreased with time down to 70. And now, as we know, the European targets are less than 55, right? So that's 1.4 millimoles per liter. And in people with recurrent coronary disease, an event, recurrent event in the next 2 years, we want to have that LDL below 40, 1 millimole per liter, so very low. And the Lipid Association of India, which I've been pretty active with, they specified even lower targets for the high-risk people. And this is a summary of the European guidelines. I'm sorry, I don't know if we can make the screen more clear, but it's a little fuzzy if we can focus it. But we know that for our low-risk people, we have looser targets of around 3 millimoles per liter, moderate risk people, 2.6 millimoles, and then, as I mentioned, 1.8 and even as low as 1.4 in most people with ASCVD. And remember, I said, if you've had a recurrent event within 2 years, the European targets are less than 40 milligram per deciliter. Our US guidelines mention, these are just the primary prevention guidelines. And again, I'm sorry you can't read it, but basically we recommend you do a global risk assessment using the ASCVD risk calculator. You can also use the new SCORE risk calculator used in Europe, I might mention, now predicts total CVD events. It used to just predict cardiovascular mortality, but now it predicts total events. So you can use that. And in our guidelines, we say if you're high risk, greater than 20%, you should definitely be on a high intensity statin. Low risk focuses on lifestyle management. Intermediate, borderline and intermediate risk, we consider a list of risk enhancing factors to further guide the treatment decision, such as family history of premature cardiovascular disease, persistently elevated LDL, chronic kidney disease, metabolic syndrome, certain female specific factors, preeclampsia, premature menopause, low birth weight babies. These can all increase a woman's risk. Also inflammatory diseases and certain high-risk ethnic groups and elevated lipids and other biomarkers like C-reactive protein. And we'll talk about LP-little-a as well. But really, we're going to focus mainly on talking about secondary prevention. And the thing to understand here is that in patients with ASCVD, there's a great heterogeneity of risk, okay? So our US guidelines point out the very high risk ASCVD contrasted with the not at very high risk. The main difference is that if you're a very high risk patient, both of them, we recommend high intensity statin plus ezetimibe if your LDL is still 1.8 millimoles per liter or higher, right? 70 milligram per deciliter or higher. If you're very high risk and it's still above that level, then consider a PCSK9 monoclonal antibody, okay? So that's for the very high risk. And so very high risk is 2 or more of these major events. So recent acute coronary syndrome, history of MI, history of ischemic stroke, symptomatic peripheral arterial disease. 2 or more of those or one of those, and multiple 2 or more of these high risk conditions, okay? So advanced age, heterozygous familial hypercholesterolemia, prior bypass or PCI, diabetes, hypertension, CKD, current smoking, heart failure, or persistently elevated LDL. So 2 of these or one of these and 2 or more of these high risk conditions defines it as very high risk. I wrote this editorial in Jack a few years ago about why is a very high risk patient important. And this was based on a nice article that Colantonio and colleagues wrote talking about how the very high risk patient overall has a 3-fold greater risk of a recurrent event than somebody not at very high risk. And if you're one of those very high risk people with 2 or more major events, then your risk is 5 times higher, okay? So dependent on if you're only had one event many years ago, you're stable CAD, or you have multiple recurrent events, your risk can vary dramatically. So we know that despite many of our statin trials, primary and secondary prevention, a lot of people still suffer events. Okay, so this is a concept that we call residual risk, okay, residual ASCVD risk. And we know that even in acute coronary syndrome people, there's still a lot of events that occur despite intensive statin therapy. So this is why you're having to do so many PCIs, because a lot of these people are still suffering events because the medical management is suboptimal. I'll briefly talk about lipoprotein(a) because you're going to hear more about this. This is a underappreciated genetic condition that is elevated in 20% of adults globally. So can you imagine 1 in 5 of you, right, may have elevated Lp(a), and the Europeans recommend that this be screened at least once in your lifetime. And levels of 50 or higher are actually levels of 60 milligram per deciliter or higher. And you multiply by roughly 2.5, so that's about 150 nanomoles per liter, is prevalent in about 20% of the population. And we know from meta-analyses, Mendelian randomization, genome-wide association studies that Lp(a) is a causal and independent factor that helps explain this residual risk. And this is a paper we published earlier this year from the AIM-High cohort, showing that that despite statin therapy, there is still a gradient of risk associated with elevated lipoprotein(a) levels. And there are newer therapies in development now pelacarsen is being investigated in the Horizon trial, which will be several years before it comes out, whether lowering that Lp(a) beyond high intensity statin therapy will prevent events. So how about what's our justification? We have different types of evidence that we're going to talk about from different types of studies that give us justification for lower LDL cholesterol targets. In the Prove It TIMI study, which you may recall, were patients with an ACS within 10 days of their ACS. They were randomized to high intensity atorvastatin 80 versus pravastatin 40. And you can see that the people who achieved an LDL 40 or below had a much lower event rate, right? They were 39% lower than if they were at 80 to 100. So the lower the LDL, the lower the greater the benefit, and hence this is in part some of the evidence that the ESC used for this 40 milligram per deciliter target if you have a recurrent event and you're very high risk. Now, if you look at different statin trials, again, the people that achieved below 50 milligram per deciliter had the lowest event rates. Okay, so again, evidence that the lower, the better. In the Improve It trial, remember this involved adding ezetimibe on top of statin therapy in acute coronary syndrome patients within 10 days. And these people had a modest 6% relative risk reduction, but because they were such high risk to begin with, the number needed to treat was 50. There was a 2% absolute risk reduction after 7 days. So again, these are in our guidelines for our recent ACS patients who still could benefit from further LDL cholesterol reduction. And in the subset that got down to below 30, look how much lower the event rate was, right? So you had further benefit. You had a 20% lower risk if you reach below 30 compared to above 70. So the benefit was even greater from achieving those lower levels. Now let's talk, since most of you are interventionalists and are familiar with intravascular ultrasound, as you know, there's a wealth of trials that involve looking at the benefits of lower LDL on plaque. And if you look at the, this is actually from statin trials, that roughly you see that you get a, that the plaque atheroma volume, this is from repeat intravascular ultrasound, is favorable towards reversing the plaque once the LDL gets down to below 70, right? So about 1.8 millimoles per liter. Below that, your plaque is more likely to regress than progress, okay? So that's, I think, a very important message to understand. Remember the Glagov trial that Steve Nissen did involved repeat intravascular ultrasound after 18 months, and people were randomized to evolocumab on top of statin versus statin alone. And overall, remember that in that trial, the people got their LDL down to about 37 compared to 93. And there was a significant change towards regression of plaque, reversal of atherosclerotic plaque from that therapy if you got the LDL down that low. And interestingly, the lower the LDL achieved with no plateau in effect. So there was no point at which there was no further benefit down to at least 20 in terms of reversal of plaque was greater without evidence of threshold, the lower the LDL got. So this is was a very important finding from the Glagov trial. And most recently at the ESC a few months ago, the Huygens trial, which also involved evolocumab, used optical coherence tomography and showed that certain plaque vulnerability characteristics, such as a fibrous cap thickness, increased, and the lipid arc, the maximum lipid arc, decreased from evolocumab therapy. So again, further evidence that intensive LDL lowering can benefit plaque vulnerability. And we also know from that study that the lower the achieved LDL, the greater the change, the increase in fibrous cap thickness. So that was a very important finding. Again, no threshold. The lower the LDL achieved, the more the fibrous cap thickness increased, okay? We know from Fourier, right, the largest PCSK9 outcomes trial that achieved a median LDL in the treated group of 30 milligram per deciliter. And these people had a 15% relative risk reduction. And importantly, this is a similar plot here showed that down to at least 20, maybe even 10, right? 10 below 10 milligram per deciliter, a continued benefit. So we have never seen a clinical trial that has brought LDL cholesterol levels down to such amazingly low levels. And this is, and the further benefit, again, no plateau in effect. So continued benefit, even down to 10. There was a 31% risk reduction in those people who got to below 10. So very important. The Odyssey trial, again, these are people, another PCSK9 monoclonal antibody. In fact, some of you here in Serbia and in Bosnia and Herzegovina were investigators in the Odyssey outcomes trial, and these people got a had also a 15% relative risk reduction. The people that got to even lower LDL cholesterol levels, though, tended to have further benefit, as much as a 31% reduction for those who got to even lower LDL cholesterol levels, like below 15 milligram per deciliter. There was that further benefit than those that did not. Okay, so this nice review article mentions that given the potential for cardiovascular benefit and short-term safety of very low LDL, it may be advantageous to achieve such low LDL in selected patients. We know statin therapy is quite safe, and if you treat 1,000 patients for 5 years, you'll prevent 10,000 patients for 5 years. You'll prevent 1,000 major vascular events and secondary prevention, 500 in primary prevention, and relatively few adverse effects, most of which are cases of diabetes. But remember that many of the people in statin trials were pre-diabetic to begin with. So it didn't take much to raise their glucose, say from 124 to 126 or something. The IMPROVE-IT trial again demonstrated that even LDL levels down to below 30 had a similar safety profile, right? This is AE leading to discontinuation, AST or ALT elevations, myalgias, myopathies, rhabdomyolysis, memory impairment, hemorrhagic stroke. Nothing was significantly different according to the LDL cholesterol achieved. Also in Fourier, the people that got to below 20 compared to 100, identical safety profile, right? any serious adverse events, new onset diabetes, cancer, cataracts, neurocognitive, liver enzymes, CK, hemorrhagic stroke over here. No difference. We know, as I showed you, that identical safety again in the people who got to below 10 milligram per deciliter, okay? So it's very important that you help educate the primary care doctors that it is safe and that the patient should know that it is safe to achieve very low LDL cholesterol levels. Since this is an interventional meeting, I wanted to mention that the people that benefit the most from intensive LDL cholesterol lowering are those who have multi-vessel disease, okay? So the more disease vessels you have, right, the higher your risk and the greater the absolute risk reduction. And look at that number needed to treat of 30, so 29. So for every 29 patients you give evolocumab who has multi-vessel disease, you're gonna prevent a cardiovascular event, okay? Greater benefit than if you don't have multi-vessel disease. Evopax is important to understand because there is a lot of interest in trying to get intensive lipid lowering therapy, such as with PCSK9s, instituted in the immediate post hospitalization phase, right after they become hospitalized, within 24 hours of a STEMI, within 72 hours of a non-ST segment ACS. And that's what the Evopax study did, and they used evolocumab on top of atorvastatin, and they were able to get, within 4 weeks, most of the patients got to target. So very aggressive, intensive LDL lowering. 90% reached an LDL below 55, 96% reached an LDL below 70. Cognitive function in Fourier again was identical. Remember, they did a sub-study called the Ebbinghaus study that had objective measures of cognitive function and showed that the lower LDL achieved was not associated with cognitive impairment. So very important to understand that. We know that loss of function PCSK9 mutations result in very low LDL cholesterol levels below 20. And these people remain healthy despite these mutations. So we know that that the low LDL achieved from such mutations can be safe. This a little bit about newer and emerging non-statin therapy. So bempedoic acid is I believe has been filed. It's approved in the United States, but I don't think it's yet available here. But this is remember, an ATP citrate lyase inhibitor that lowers LDL about another 15% in combination with ezetimibe 35%. Cardiovascular outcomes data, though, are pending. Evolocumab focuses on homozygous FH, lowers LDL about 50%. Inclisiran is approved here in Europe and not in the United States yet, but we expect approval in the next few months. So you have this drug available now, although obviously it's costly and we got to work with payers, with the pharmaceutical company needs to make this more available. But this is an RNA interference therapy that lowers LDL about 50%. And what's interesting is it's the closest thing we have to maybe a vaccine against atherosclerosis, because you give it at baseline 3 months and every 6 months later, and you get this time average reduction of 50%. But we'll see if this takes off. It has to be given by a healthcare provider. It's an IV infusion. So it's not as easy to administer as a PCSK9. Pelacarsen targets Lp(a), as I mentioned, again, several years before that's available, and another silencing RNA therapy to lower Lp(a). This is an example of the Orion data from Equizerun. So look at that. Baseline, 3 months, 6 months, 6 months later, and 50% LDL reduction. So I wrote this editorial about when is it appropriate to lower LDL below 30. We've talked about our guidelines and the European guidelines, and now the Lipid Association of India recommends even further LDL reduction. So to conclude, we've talked about how our ASCVD patients have a wide range of risk. So you need to look at when they had their event, right? The people with more recent events are at higher risk of a recurrent event. Have they had recurrent events in the last 2 years, right? That's a group that the ESC specifically picks out for even an LDL target below 1 millimole per liter. Many people, there's already a wealth of evidence from statin trials, ezetimibe and PCSK9, that you get greater benefit the lower the LDL achieved. And there seems to be no threshold below which there's no further benefit, right? So this is something that we learned from the PCSK9 trials. The imaging studies also show greater regression of atherosclerosis with lower LDL achieved, right? Once the LDL is below 1.8 millimoles per liter, you start to get regression, more regression of atherosclerosis than progression. So that's important to understand. And the further you lower the LDL, the more regression you'll get. Emergent non-statin therapies we talked about may have a very important role to further address this residual risk. So I think to conclude, it's important for, for all cardiologists and really the interventional cardiologists in this audience to really think about this as very complementary to the interventions that you are doing. Okay, so the interventions that you're doing are very, very important, but we also want to make sure the medical therapy is optimized to prevent their likelihood of restenosis and reduce the likelihood that they'll need further revascularizations. Okay, so with that, Vala, and you can come visit me at my beach here in California. Thank you very much. Okay.
Do you have any questions from audience, from Nathan? Professor Belestin?
Can I ask you about the role of, there is more talk about Lp(a). Some comments about that, because now it is becoming again important. So do you have any, you show the drug that might work with the Lp(a), so maybe some comments about, should we measure in the patients and in whom patients?
Exactly, yeah, good question. So what we're recommending and pushing at my institution, which is more consistent with our US guidelines, obviously it might be a stretch to measure in everybody. The ESC, remember, recommends it be tested at least once in everybody's lifetime. But it's clear that our ASCVD patients are at higher risk, and this is one reason for this residual risk, the people that have elevated Lp(a). So I think universally in all your ASCVD patients, so people with a prior MI, ischemic strokes, peripheral arterial disease, if this has not been measured, it should be measured. And right now, since we don't have any proven therapies to lower it that are available, the idea is that if you find somebody with an Lp(a) above, especially above 70 milligram per deciliter, which is 175 nanomoles per liter, that you be more aggressive with your LDL lowering therapy. So we really view it now mainly as a risk enhancer, but if pelacarsen and other therapies prove to show benefit in further lowering events beyond statin therapy, then it really is, I think, very promising that it's going to be a target, just like how we have LDL as a target, that Lp(a) is going to be a target as long as the clinical trials are positive. Anything else?
Idemo dalje. Idemo dalje, ako možemo. Naš sledeći prezenter jeste profesor Slobodan Obradović sa VMA iz Beograda. On praktično ima predavanje u vezi plućne embolija, kontraverze u lečenju plućnih embolija. Profesor Obradović je bio sprečen da dođe i koliko ja znam, Aleksandre, on je snimio svoju prezentaciju i vi ćete sad nju pustiti. Znači imat ćemo snimljeno predavanje profesora Obradovića sada.
Dragi kolege, dobro veče. Ja sam profesor Obradović sa klinike za kardiologiju VMA i ja ću vam govoriti o nekim novinama u perkutanim intervencijama u akutnoj i hroničnoj plućnoj tromboemboliji. Po programu moja tema je bila dileme u lečenju plućne tromboembolije i kao što vidite, autori su moja malenkost, dr. Boris Đudović i profesor Stavros Konstantinides, koji je dao značajan doprinos ovom revijalnom radu i ja preporučujem svima koji se interesuju za embolije pluća da pročitaju ovaj rad, jer je on dosta neobičan i iz ugla je ljudi koji se klinički bave ovim problemom i koji su uočili glavne probleme vezane za dijagnostiku i lečenje plućne tromboembolije. Pošto je to sve u radu, ja ću vam prikazati nešto vezano za interventnu kardiologiju. Prvi slučaj je žena kod koje je u Zemunu dijagnostikovana high risk plućna tromboembolija sa disfunkcijom desne komore i sa velikim slobodnim trombom koji je negde bio zarobljen u trabekulama desne pretkomore srca. Ona je imala na skeneru i velike mase, međutim, trombne mase, međutim, pošto je imala i sinkopu i povredu glave, nije se mogla primeniti klasična trombolitička terapija, ona je nosila i rizik od fragmentacije ovih trombova koji bi mogli da izvrše dodatnu opstrukciju izlaznog trakta desne komore, a i plućnih arterija, a već je postojala veliko trombno opterećenje u samim plućnim arterijama. Što se tiče nekog izvora embolije, pacijentkinja je imala longetu na desnom stopalo zbog povrede tetiva prilikom pada na stepenicama. Imala je još jedan podatak koji se kasnije ispostavilo da je bitan, a to su bolovi u epigastrijumu, ali taj deo nije toliko bitan za ovo samo predavanje. Vidi se ovde gradijent pritiska na trikuspidnom ušću koji je 52 mm življenog stuba, tako da njen pritisak sistolni u desnoj komori je bio preko 60 mm življenog stuba. Veličina desne komore je bila oko 4,5 cm, a negde granični tapse 1,6, 1,7 cm se meri na prijemu bolesnice. Videli ste one velike trombne mase u desnoj pretkomori koje su negde zarobljene u trabekulama, a koje su mogle da se fragmentiraju, pogotovo primjenom fibrinolitičke terapije i da pogoršaju čak stanje bolesnice. Mi smo primenili aspiraciju tih trombnih masa uz pomoć uvodnika od 7 frenča, dužine 65 cm, koje smo doveli na ulaz desne pretkomore. Na spoljašnji deo tog uvodnika smo nakrčili špric na navoju koji može da napravi vakum, a koji je u stvari iskorišćen iz seta za tromboaspiraciju za koronarne krvne sudove. To je špric znači o nekih 50 ml i u 2 navrata smo znači preko tog uvodnika uradili vakum u samoj desnoj pretkomori. A nakon toga smo implantirali ovaj pigtail u znači praktično završnu granu desne plućne arterije gde smo na skeneru videli najveće trombne mase. Ono što smo izvukli nas je, tako kažemo, začudilo i prvi put smo videli tako nešto, znači uspeli smo da aspiriramo trombne mase iz desne pretkomore i ovde vidite one su znači kompaktne prilikom izbacivanja iz samog špice i kad smo ih razdvojili vidite da su to više tih froncli tromba koji su bili zarobljeni u trabekulama desne pretkomore. Preko onog pigtail katetera je pacijentkinja dobila infuziju aktilize od 1 mg na sat i već posle negde 4 mg je došlo do povećanja hematoma iznad desnog oka. Podsjetit ću vas da je pacijentkinja imala sinkopu i spoljašnju povredu lacerokontuznu ranu iznad desnog oka i onda smo zaustavili dalje primenu trombolize preko katetera. Ovde vidite srednji arterijski pritisak, znači prilikom same tromboaspiracije je bio 36 mm živinog stuba, a nakon vađenja katetera iz desne plućne arterije on bio već 30 mm živinog stuba, dakle imamo jedno poboljšanje na vrlo malu dozu trombolitika koja je data preko katetera. Ovde vidite odmah posle vraćanja iz sale eho nalaz i ovde vidimo taj kateter, znači pigtail koji je uopšte postavljen u desnu plućnu arteriju i vidimo da više nema trombnih masa. Ovo je subksifoidni presek, ovo je presek 4 šupljine, znači vidi se samo kateter, vidi se disfunkcija i uvećana desna komora, ali više nema ni traga od onih trombnih masa koje su se nalazile u desnoj pretkomori. Ovo je skener koji je urađen par dana kasnije gde vidite da trombne mase više nisu bile velike u samoj desnoj plućnoj arteriji, gde je i stao sam kateter, da imamo ostatke trombnih masa u donjoj levoj lobarnoj arteriji pluća. Ovo je jedan od eho nalaza tokom same hospitalizacije, još uvijek imamo desnu komoru koja je nešto veća od leve. Ovo je u tom momentu urađeni strain desne komore gde vidimo jednu hipokineziju slobodnog zida desne komore. Ovo je pred sam otpust, pacijentkinja je otprilike 10 dana bila u bolnici jer morala je da se uradi i gastroenterološka dijagnostika, jer je nađen i tumor u predelu glave pankreas i ovde vidite sad već manju desnu komoru koja se dobro kontrahuje, malu površinu desne pretkomore, pritisak u gradijentu, stvari pritiska na trikuspidnom ušću je sada negde oko 25 mm živinog stuba, a tapse vidite ovde 2,34 cm, što je značajno poboljšanje funkcije desne komore, praktično normalizacija. Na prijemu smo imali EKG koji je u stvari pokazivao jedno teško opterećenje desne komore sa širokim i niskudnim S zupcima u praktično ST segment, a u stvari S zupci su prošireni i duboki i u D1 i AVL. Ovde vidimo kako se oni sužavaju i kako dobijaju jednu normalnu konfiguraciju kod starog bloka desne grane. Pacijentkinja u stvari ima jedan intermitentni blok desne grane kao njen osnovni ritam i pre same embolije pluća. Sad ćete vidjeti drugu grupu bolesnika, mi vidimo kao veliki problem subakutnu plućnu emboliju, to je praktično embolija od 10. dana do 3 meseca. Tu ima dosta bolesnika koji mogu imati dosta velike tegobe sa velikim trombnim masama u plućnim arterijama, a dijagnostika hronične tromboembolijske plućne hipertenzije se preporučuje 3 meseca. Šta raditi u ovom prostoru između, da li se može sprečiti razvoj hronične tromboembolijske bolesti pluća. Evo ga pacijent koji ima 56 godina i 4 nedelje pre prijema kod nas upućen je samog kliničkog centra, znači imao masivnu plućnu tromboemboliju, a prethodno je bio hospitalizovan zbog COVID-19 u Batajnici gotovo mesec dana. On je već na prijemu i kod nas, još uvek je hipoksemičan i praktično NIHA 3., 4. klasa srčane insuficijencije. Ovde vidite, znači, kateter je u desnoj plućnoj arteriji i vidite odlivak velikog tromba koji ometa protok i kroz gornji i kroz srednji režen desnog pluća. Ovde vidite balone od 5 mm u promeru koje su ulaze i prolaze kroz trombne mase i za gornji režen desnog pluća i za srednji režen desnog pluća. Ovde vidite znači kako prolaze za segmentne arterije za srednji režen. Ovde vidite sada kako je napravljen jedan tunel uz pomoć balona gde prolazi kontrast. Ovde smo se sada spustili na srednji režen i zbog velike subokluzivne trombne mase smo implantirali stent od 5,5 mm. Evo ovde vidite rezultat implantacije tog stenta i 2 dana kasnije vidite kako stent stoji u arteriji i vidite kako se cijela arterija, to je znači grana za anteriorni segment gornjeg režnja desnog pluća praktično potpuno sa svim svojim bočnim granama prikazuje. Ovde su sada grane za srednji režen pluća, opet jedan odlivak velikog tromba, opet veliki baloni kojima pokušavamo da napravimo prolaz. Imamo još uvek subokluzivnu leziju tog subakutnog tromba koji se više ne može aspirirati, koji je čvrsto zalepljen za zid krvnog suda, opet jedan veliki stent od 5,5 mm. Ovde vidite protok kroz sam stent i ovde vidite skener 2 dana kasnije, vidi se sam stent i vidi se da srednji režen pluća praktično se ispunjava krvlju sa svojim subsegmentnim granama. Ovo je EKG bolesnika na dolasku, vidite da je tahikardičan, da ima duboke S zupce u D1 i AVL. Ovde vidite posle 2-3 dana od intervencije kako su se ti S zupci smanjili i kako više nije tahikardičan. Ovo je sledeća pacijentkinja koja je također u subakutnoj fazi, ženskog je pola, ima 26 godina i pre 2 meseca imala akutnu emboliju pluća, moguće da imala mali recidiv embolije pluća koji se manifestuje kao infarkt pluća sa desne strane, sa jakim pleuralnim bolovima i sa malim hemoptizijama. I mi smo uradili skenersku angiografiju, videli potpunu okluziju leve plućne arterije. Evo ovde vidite znači na jednom poprečnom preseku, ovde vidite jedan bočni presek i ovde vidite jedan sagitalni presek, praktično potpuna okluzija plućne arterije sa leve strane. Pritisak je bio visok, oko 50 mm živinog stuba u desnoj komori. Ovde vidite scintigrafiju, perfuzija se prikazuje samo desnog pluća, levog pluća uopšte nema. Ovde vidite sada kateter koji je u levoj plućnoj arteriji, ništa ne ide u levo pluće, potpuno je okluzija. Ovde imamo znači opet pigtail kateter koji je zaglavljen u trombnu masu, ovde vidite odlivak samog tromba i preko tog katetera je, znači pošto smo mislili da se radi o jednoj dodatnoj embolizaciji ili trombozi na mestu možda subtotalne stenoze, smo dali 20 mg aktilize tokom 24 sata i ovo je snimak posle te kateterske trombolize i vidite da se pojavljuje donja lobarna arterija za znači levi donji režanj pluća. Pristupamo jednoj složenoj, dugoj perkutanoj intervenciji gde uspevamo da otvorimo donju lobarnu arteriju i da stavimo jedan veliki stent isto od 5,5 mm u proksimalni segment te arterije i videli ste protok koji smo dobili. Ovde se sada vidi 2 meseca kasnije perfuzija tog donjeg grežnja levoga pluća koja uopšte nije bila prisutna, a ovde se vidi i kontrolna, znači plućna angiografija, praktično sve grane donjeg grežnja levog pluća se prikazuju, pacijentkinja više nije imala plućnu hipertenziju, normalizovala je i nalaze vezane za staznu jetru i za proteinuriju koje je imala. Znači, ovo je bila jedna iznuđena intervencija kod mlade pacijentkinje koja je imala praktično desnostranu srčanu insuficijenciju. Ono što negde baveći se ovim problemom je da neka klinička i značajna podela hronične tromboembolijske bolesti pluća treba da bude drugačija nego što se inače koristi. Imamo pacijente koji imaju pretežno proksimalne organizovane trombne mase i kod tih pacijenata je definitivno plućna endarterektomija izbor lečenja i maltene ti bolesnici mogu da se izleče. Međutim, jedan značajan broj bolesnika, možda čak i veći broj nego što kako se zove su ovi prvi su bolesnici sa difuznom bolešću koji imaju i proksimalnu i distalnu tromboembolijsku bolest pluća gde se mora raditi kombinovana terapija i plućna endarterektomija i nastaviti sa balon angioplastikama, naravno uz lekove za plućnu hipertenziju. Imamo bolesnike sa distalnom bolešću gde se može raditi balon angioplastike, a nekada je bolest toliko distalna i difuzna da se ni balon angioplastike ne mogu adekvatno primeniti, gde su lekovi pravi izbor lečenja, a tu je adempas verovatno najbolji izbor za te bolesnike. Ovde vam prikazujemo jednog bolesnika koji ima svega 50 godina, kome je hronična tromboembolijska bolest pluća detektovana još 2011. Urađena je prva balon angioplastika na VMA još 2017. a 2018. u Bad Neuhamu urađena plućna endarterektomija. On se nažalost vratio posle operacije još gori klinički nego što je otišao. Ima NIH 3-4 posle EP-a i srednji pritisak, znači meren opet desnom kateterizacijom bio 61 mm živinog stuba i posle toga su urađene 3 intervencije sa balon angioplastikama posle plućne endarterektomije u Institutu za plućne bolesti Sremske Kamenice, znači profesor Matijašević, Uroš Batranović, Srđan i ja smo radili te intervencije i ovde vidite recimo posterobazalni segment za donji režanj desnog pluća, praktično urađena endarterektomija i vidite da se kasnije grane, znači nakon te segmentne arterije više ne prikazuju i mi smo pristupili intervenciji, vidite žicu koja prolazi kroz hroničnu totalnu okluziju i rade se balon angioplastike u više nivoa, radi se kissing takođe. I pogledajte, znači od ničega dobile su se 2 subsegmentne arterije i to je vrlo veliki deo pluća je perfundovan na ovaj način. Nakon toga smo nastavili da radimo i granu za posterolateralni segment donjeg režnja. Takođe, evo je žica, znači koja je prošla kroz mesta stenoze, baloni različitih veličina i ovde vidite kako se dobro dobio protok sada kroz periferiju sa odličnom venskom fazom, znači i gornja i donja vena, znači iz ovog segmenta se odlično prikazuju. Eto, dosta smo proširili načine i mogućnosti lečenja i akutne i subakutne hronične tromboembolijske bolesti pluća i pozivamo sve da zajedno radimo na ovom problemu i imamo veliki registar ovih bolesnika koji sad već ima oko 1500 bolesnika sa akutnim embolijama pluća, a takođe i preko 50 bolesnika sa hroničnom tromboembolijskom bolešću pluća, tako da imamo puno materijala i puno toga smo naučili i spremni smo da to podelimo sa svima. Hvala puno na pažnji.
Srbiju nam Bože vrati, moliti se za naš rod, složeni srcu braću dragu, na svak dičan slavan rad, stoga biće poraz dragu, a najjači srpsku grad. Nek na srpskoj blista grani, bratske sloge zlatan plod. Bože spasi, Bože hrani, srpske zemlje, srpski rod. Srbiju nam Bože brani, moliti se sav naš rod.
Hvala našim prijateljima i malim drugarima iz Hora i Snjažica. Pa kao što je red, sad bismo započeli sa ovim, da kažem, manje zvaničnim delom, gde ćemo ukratko predstaviti rezultate naše angiosale za prethodnu godinu. Ako možemo samo prezentaciju. Ja je ovde vidim na monitoru, samo da se vidi na displeju. Ovo je, kao što znate, već 7. godina kako se družimo i boga mi brzo je prošlo. Počeli smo kao obično sa idejom da to bude regionalni skup posvećen interventnoj kardiologiji. Sami ste učestvovali u tome i pomogli da u stvari ovo postane veliki kongres, da postane međunarodni kongres. Zahvalio bih velikom broju naših prijatelja, učitelja i predavača koji svake godine pomažu u realizaciji ovog kongresa. Zahvalio bih našim prijateljima iz inostranstva koji nas podržavaju u realizaciji kongresa. Posebno bi se zahvalio profesoru Sijevu koji je 4. godinu sa nama i svake godine nam pomaže u realizaciji najkompleksnijih pacijenata koje mi inače ne bismo uradili. Zahvalio bi se i profesoru Vongu koji je bukvalno došao sa drugog kraja sveta. Thank you, Professor Wong. Thank you, Professor Siev, for coming and support our meeting. Ove godine uradili smo, kao što vidite, ovoliko, znači 430 koronografija, 260 PCI-a, dominantan broj su u stvari bili STEMI i non-STEMI, što je i naš cilj i kako nas je zavetovao profesor Nedeljković, znači to treba da bude naš osnovni posao. Elektivni program je kod nas uvek bio u drugom planu. Standardni broj pacemakera, kao i do sada, uradili smo 2 CRT-P-a, počeli smo i sa tom intervencijom, tako da ćemo to nastaviti u budućnosti, pored ICD-a koji se već 6 godina uspešno ugrađuje. Imali smo 37 zamena, što je otprilike nekih 30% i to nas svrstava u rang ozbiljnih pacemaker centara, s obzirom da imamo 30% zamena od osnovnog broja implantacije. Ove godine smo počeli sa periferijama, znači uradili smo 4 periferije. Pored periferije koje smo uradili, aktivno smo učestvovali na predavanjima, držali smo predavanje i učestvovali na svim ovim kongresima u toku ove godine. Ove godine, kao što vidite, imat ćemo 2 sale, ovu centralnu salu i pomoćnu salu Kalna. Uživo ćemo imati prenos preko Zooma, za sada iz Kalne ide bez problema, otklonit ćemo nedostatke koje imamo u ovoj sali. Kao što ste videli iz programa, kao nikada do sada, 106 predavanja, 10 predavanja industrije, 22 sesije, ukupno 90 predavača i imat ćemo dodatno organizovana 2 testa koji će biti u subotu za one koji to budu želi da slušaju. Inače, kongres je akreditovan kao međunarodni kongres, a ova 2 testa će doneti još dodatnih 10 poena učesnicima testa. Imat ćemo uživo prenos iz angio sale, kao i do sada tradicionalno profesor Sijev, ovog puta će naš dr. Marko biti podrška u intervenciji i po prvi put ćemo uraditi PTCA, znači na periferiji, radit ćemo desnu ilijačnu arteriju i levu superficijalnu femoralnu arteriju. To će nam pomoći naši prijatelji iz Italije i iz Bugarske, Farat i Oktaj. To ćemo videti sutra, znači uživo ceo taj prenos. Kao što ste videli, ovo je bio taj svečani deo, šta smo do sada uradili. Sada bih zamolio kod direktora ovog simpozijuma, odnosno ovog kongresa, profesora Nedeljkovića, da našim gostima i predavačima dodeli priznanje i nagrade. Prvo bih pozvao profesorku Marinu Deljanin-Ilić, našu učiteljicu od koje, Boga mi, svi učimo svih ovih godina, da i profesor Nedeljković uči zahvalnost. Tu je naravno i čovek od koga smo mi naučili EKG i od koga i dalje učimo EKG, profesor Steva Ilić. Profesore, izvolite. Izvolite.
Ja moram da, kad su ova 2 čoveka u pitanju, 2 profesora, 2 velika učitelja, profesorka Marina Deljan-Ilić i profesor Steva, to su ljudi koji su svima nama dali postulate i premise šta treba da radimo i kako treba da radimo. Ja se sećam kad sam počinjao nekih 1985. bili su novine u kardiologiji tada u Niškoj banji. Stevina predavanja i Marina predavanja su bila možda ispred svih onih predavanja što sam čuo po Americi, po celom svetu, edukativna, precizna i nadasve iz tog centra mi imamo mnogo radova na evropskim kongresima, na svetskim kongresima, na američkim kongresima. Smatram da je Niška banja jedna od centara u ovom delu Evrope, baš zahvaljujući njima, koja je rasadnih kako nauke, tako i učenika kao što smo mi koji smo izrasli iz te škole. Hvala vama, hvala Stevo, hvala Marina.
Sledeći je naš prijatelj, profesor Milovan Petrović, direktor klinike za kardiologiju Instituta Sremska Kamenica. Kad smo već tu, profesorka Anastazija, molim vas, Stojišić Milosavljević.
Inače, od 27. decembra aktuelni predsjednik Udruženja kardiologa Srbije. Izvoli, Anastazija.
Namerno sam ovo